This is Chapter 21, Postpartum Complications. Postpartum hemorrhage. Leading cause of maternal death worldwide, postpartum hemorrhage traditionally defined as loss of more than 500 ml of blood after a vaginal birth or 1,000 ml after a cesarean birth. It is life-threatening with little warning, often unrecognized until profound symptoms occur. Diagnosis is often based on subjective observations. Postpartum hemorrhage is classified as early or late with respect to the birth. Early or acute is within 24 hours of birth. Late is secondary postpartum hemorrhage occurs more than 24 hours of birth but less than 6 weeks after birth. So let's discuss some etiology and risk factors. Uterine atony is marked hypotonia or relaxation of the uterus, lacerations of the genital tract, hematomas or retained placenta, non-adherent retained placenta or adherent retained placenta. If you look in your book, box 21-1, page 531, it lists more risk factors. Inversion of the uterus. This is a turning inside out of the uterus, potentially life-threatening, happens about 1 in 3,000 births. Subinvolution of the uterus. This happens usually late postpartum bleeding, retained placental fragment, and pelvic infection. Subinvolution of the uterus is delayed return of the enlarged uterus to its normal size and function. Causes can be retained placental fragments or pelvic infection. Signs and symptoms: prolonged lochial discharge, excessive bleeding, irregular bleeding, and sometimes hemorrhage. Early recognition is critical. First step is evaluation of contractility of the uterus. Firm massage of the fundus is critical. Management is directed toward increasing contractility and minimizing blood loss. IV fluids, LR, oxytocin drip, prostaglandins, manual inspection of the perineum. Early recognitions: evaluate contractility of the uterus. If the uterus is hypotonic, we want to increase contractility and minimize blood loss. If the uterus is firmly contracted and bleeding continues, we must locate the source of bleeding and stop that bleeding. Assess the perineum, cervix, vaginal area, uterus, order labs, H&H, coag studies. Initial treatment due to uterine atony is firm uterine fundal massage. There have been some herbal remedies used outside of the United States, but there's no evidence to support their use. Be prepared to intervene quickly. Acute assessment of circulatory status is essential. The woman will be on all monitors. She will likely need invasive monitoring. Always remember to keep the woman and her family informed of all interventions taking place. Remember, if this woman's bleeding, hemorrhagic hypovolemic shock can take place. There will be medical management, nursing interventions, fluid or blood replacement therapy. Remember, standard of care for bleeding emergency allows for provisions to be made for nurses to initiate actions independently in the event of an emergency. You want to avoid this. So we want to know how to intervene and treat hypovolemic shock quickly. So remember, what is the definition of shock? It's inadequate tissue perfusion and oxygenation. It affects cellular injury, organ failure, and equals death. So, types of shock. We have septic and spinal shock, hypovolemic and hemorrhagic shock, obstructive shock, cardiogenic shock, and anaphylactic shock. For today's lecture purposes, we need to speak of hypovolemic and hemorrhagic shock. So, the clinical diagnosis: your central nervous system, you would have an altered mental status, central venous system, tachycardia, you would have an increased tachycardia, diastolic would be down, pulse pressure would be down, your MAP would be decreased, cardiac output would be decreased, respiratory, you would have tachypnea, O2 requirements would be increased, decreased urinary output, you might have an ileus. Your skin, progressive vasoconstriction, so you would have cool extremities because you're shunting. You want to look at your history of your patient for clues about what's going on. These are all things that you might assess for in your clinical diagnosis of shock. So let's look at laboratory support. Metabolic acidosis, all right? Metabolic acidosis, second to inadequate tissue perfusion, shift to anaerobic metabolism, production of lactic acid. This is very serious. The patient is becoming very ill. The patient's body is trying to compensate. When you have a patient hemorrhaging and in hypovolemic shock, there's a shunting effect. The blood is shunting to the major organs in a survival mode. Due to the shunting mechanism, the kidneys and the skin do not get perfused, so they will have a cold, clammy skin, a decreased urinary output. What is happening is the adrenal glands release catecholamines. The arterioles and the veins in all the major organs are constricting, causing this shunting effect, and the available blood is diverted to the blood in the heart. This is just a video on YouTube about hypovolemic shock that you can go to and watch. This gives a clinical picture of a patient in hypovolemic shock. This is another clinical picture of a patient in hypovolemic shock. Let's talk about coagulopathies. Idiopathic thrombocytopenia purpura is ITP, autoimmune disorder. Von Willebrand disease, type of hemophilia. Disseminated intravascular coagulation. It's a consumptive coagulopathy, consumes large amounts of clotting factors, widespread external bleeding, internal bleeding, or both. ITP is an autoimmune disorder in which the antiplatelet antibodies decrease the lifespan of the platelet. Diagnostic findings are thrombocytopenia, capillary fragility, and increased bleeding time. We'll talk about this more in class. Postpartum infections, puerperal infection, presence of a fever of 38 degrees Celsius, which is 100.4 degrees Fahrenheit or more, on 2 successive days on the first 10 postpartum days, not counting the first 24 hours after birth. Common puerperal infections include UTI, respiratory tract infection, mastitis, and breast infections. Most common organisms are Staphylococcus aureus, gonococci, coliform bacteria, and Clostridia are less common. Postpartum infection is a major cause of maternal morbidity and mortality throughout the world. Postpartum psychological complications. Mental health disorders in postpartum period have implications for the mother, the newborn, and the entire family. They interfere with attachment to the newborn and family integration. They may threaten safety and the well-being of the mother, the newborn, and other children in the family. Mood disorders. They account for 80% of women experiencing mild depression or baby blues. Symptoms resolve usually within a few days. However, 10 to 15% of women experience more serious depression following birth. Paternal postpartum depression is real. You can read about this in your textbook. Postpartum depression without psychotic features. Postpartum depression is an intense and pervasive sadness with severe and labile mood swings. Medical management, usually antidepressants, anxiolytic agents, mood stabilizers, and electroconvulsive therapy have been used. Psychotherapy focuses on the fears and concerns of the new responsibilities and roles of the mother, monitoring for suicidal or homicidal thoughts. Postpartum depression with psychotic features. Postpartum psychosis syndrome characterized by depression, delusions, and thoughts of harming either the infant or herself. Psychiatric emergency. It may require psychiatric hospitalization. It's associated with bipolar or manic depressive disorder. How do we care and treat for this? Screen for postpartum depression, nursing care on the postpartum unit, nursing care in the home and community, referrals to the proper places, providing safety, psychiatric hospitalization if needed, psychotropic medications as ordered, and other treatments for postpartum depression. When there's a maternal death, it's an emotional toll on the nursing and medical staff. Mortality and morbidity review of the chart is completed. Critical incident debriefing is completed. Attending funeral services is allowed for the staff, and there's follow-up grief counseling for the staff. This is the end of Chapter 21.